Hello, everyone. My name is Feng Wenfo. I'm currently a first-year cardiology fellow at Suma Health System. Thank you for listening to my research presentation about language barrier, a determinant for disparities in ED assessment and management of chest pain. According to the literature, there is 8.6% of the U.S. population who have limited English proficiency called LEP. LEP patients reportedly have lower cardiovascular health literacy, more reluctance to seek care, and difficulties to convey their symptoms. In addition, the language interpreter service availability and usage also vary among healthcare facilities. These challenges combined lead to a higher diagnostic test, higher rate of admission, and a longer hospital stay in LEP patients. This negatively impacts the care provision and patient experience in LEP population. The purpose of our study is to examine whether disparities exist in the ED diagnostic assessment and therapeutic management of chest pain between LEP and English proficient EP patients at our community hospital. We hypothesized that LEP patients receive less diagnostic tests and treatments for chest pain assessment and management compared to their EP counterparts. Our study is a retrospective cohort study that identified all LEP patients above the age of 18 years old presenting with chest pain to our hospital ED from September 2022 to September 2023 and matched a random sample of EP patients in a 1:2 ratio. We studied the rates of labs, including NT-proBNP, troponin, CK-CKMB, D-dimer toxicology screen, and images including ECG, chest CT, telemetry, and chest X-ray, and therapies including cardiology consult, opioids, NSAIDs, antiplatelets, anti-anginals, heparin infusion, benzodiazepine, TPA, emergent catheterization, that order within the first 24 hours of patient presentation. Our covariates include sex, age, history of comorbidities including diabetes, heart failure, hypertension, hyperlipidemia, coronary artery disease, asthma, COPD, tobacco or drug use, obesity, and depression. And we use chi-square and t-test for categorical and continuous variables for the statistic part of the study. There were 690 encounters with 239 LEP patients and 451 EP patients included in our study. Only 71% of our LEP patients were documented with interpreter service used. The two cohorts were similar in sex and age. However, EP patients carry significantly more studied comorbidities than LEP except for hyperlipidemia, and EP patients were also less likely to self-drive and use government plans of insurance compared to EP patients. EP group also received significantly more troponin, CK-CKMB, D-dimer, drug screen, chest CT, and cardiology service console than LEP with all p-values less than 0.05. No differences were found in the utilization rate of ECG, chest X-ray, telemetry, and NT-proBNP for diagnostic workup. In addition, more opioids, antiplatelet, except for prasugrel, anti-anginal, benzodiazepine, heparin infusion, and emergent catheterization were administered to EP compared to LEP patients, with all p-values less than 0.05. In summary, our study highlights that there's only 71% of LEP patients with documented use of interpreter service. EP group also received the majority of the study diagnostic workup and therapeutic plans at a significantly higher rates compared to LEP patients. Comorbidities difference, cultural perception, and language interpreter use in LEP patients may all contribute to these trends of disparities, which require further investigation. Thank you for listening to my presentation.